Good afternoon, everyone. My name is Cindy Mers, and I am the Vice President of the Suburban Hospital Foundation. And I am so honored to have so many of you joining us this evening for the second in our clinical innovation series. Tonight, we're going to be focusing on cardiac care. Again, our first webinar was also on cardiac care. And you may have noticed that the number of participants that you may have seen on the original invitation has reduced a little bit. And I have to tell you, it's going to reduce possibly a little bit more. We were expecting to have 3 amazing presenters here with us tonight, and 2 of them are actually still stuck in surgery right now, helping to save the lives of some of our own community members. So, and sometimes that happens in healthcare, but we are thrilled that you are here, and I am especially pleased to tell you that Dr. Virginia Colliver is here with us this evening, and she, as a cardiologist and a specialist in women's healthcare, can really actually give us a lot of information about what Dr. Hashmi and Dr. Hassan were also going to talk about. So we're going to allow Dr. Colliver to do her presentation. Dr. Hassan may still be joining us if he is able to, get here and finish up the procedure that he's working on right now. If that doesn't happen, please let me assure you that we will invite you to another webinar, and we will feature these wonderful physicians and surgeons at that time as well. But again, I am so grateful to have you here with us tonight, and I'm not going to take too much time before I turn this over to Dr. Colliver for her presentation. But I did just want to let you know, that we all know that this has been such an interesting and challenging 16 months, especially with so much emphasis and so much focus on healthcare as we address the pandemic, and really now have worked so hard in the area of vaccines. So, focusing on some of the other issues that surround our health and our good health as we try to stay healthy, particularly in this challenging time. Cardiac care is one of the most important topics, and we're thrilled to have the opportunity to speak with you about that this evening. So without further ado, I'm going to turn this presentation over to our first speaker, Dr. Virginia Colliver, and she will speak with us about women and cardiovascular health and prevention, and then we'll ask her to dive a little bit into the topics that our other presenters were going to speak about. Dr. Colliver, thank you so much for being here with us tonight, and for stepping in as the star of the show. We appreciate that very, very much.
I'm not usually the star of the show, but I'm happy to start off. I have a set of slides that we're going to pull up for you here in just a moment. So I want to thank Cindy and the Suburban Hospital Foundation for allowing me to speak on women and heart diseases, a very important topic that I feel very passionate about, and I'd like to share some of this with you and the foundation community. Later, I will try to also kind of touch on some of the very interesting cardiac interventions that are done at Suburban Hospital. We are very lucky to have Hopkins expertise locally in our community. So hopefully some of the speakers will be able to come back and share their thoughts with you. But I will touch on some of this kind of like on the fly. Women and heart disease is a very important topic. I see it every day in my cardiology practice, and I'll go ahead and start speaking on it. Next slide. Heart disease is very prevalent in women. It's the #1 cause of death among women in the United States. Approximately 1 out of every 3 female deaths can be attributed to heart disease. This is approximately 400,000 deaths per year from cardiovascular disease, contrasting with about 40,000 deaths per year from breast cancer in women. The awareness of the prevalence of heart disease is increasing. Up to about 50% of women surveyed are aware of this fact. Coronary artery disease can be defined as vascular disease limited to the arteries on the surface of the heart. We call them the epicardial coronary arteries. You can see in the bottom picture, a picture of a healthy artery. The lumen is nice and clear, and the blood can flow distally to the heart muscle. In some people with risk factors, which we will discuss later, some initial fatty deposits can occur. And this is typically 10 years before the initial heart attack. And so heart disease starts much earlier than when you're diagnosed. The fatty deposits can grow into plaque that obstructs blood flow. And if the plaque ruptures or if the plaque continues to grow, you can get complete occlusion or blockage of the arteries. The arteries, when they're blocked, are not able to deliver oxygen to the heart muscle. And if this is acute, the heart muscle will die. And this is what we call a heart attack or coronary occlusion. Next slide, please. For the past 3 decades, there have been dramatic declines in heart disease mortality for both men and women, particularly if you look at an older population, age group 65 years, the 65 years age group. But recent data suggests that these improvements in the incidence and mortality of heart disease is not the same in all age groups. So particularly if you look at young women, women under the age of 55 years, they're not seeing the same declines that we're seeing. And we think that this is due to increasing rates of hypertension, diabetes, and obesity in young women. Next slide. There are gender differences when we look at heart disease in women. Women tend to be 10 years older than men when they present with heart attacks. Because they are older, they present with more medical comorbidities. This does impact their overall health. Women with heart attacks also have a worse prognosis than men, poorly understood why. Might have to do with medical treatment and poor access to interventional treatments. Women are more likely to wait before presenting for medical attention. Next slide. There's some gender disparities when we look at heart disease in women. Women are less likely to receive preventative treatment. We'll talk about some of the examples of preventative treatment. Treatment tends to be less aggressive, and treatment doesn't always achieve the optimal effects in many cases. For example, when we talk about hypertension, the goal blood pressure is 120 over 80 millimeters of mercury. The reason why that's a goal blood pressure is because it's been shown that that blood pressure will protect the heart from heart attacks and strokes. So many times women are started on blood pressure medicine, but maybe the medicines aren't titrated to the point where we get to this goal blood pressure. Women are also less likely to participate in cardiac rehabilitation. We have an excellent cardiac rehabilitation program at Suburban Hospital. Cardiac rehabilitation is a supervised exercise program. It includes so much more than just exercise. There's monitoring, there's also nutrition and psychological support. And cardiac rehabilitation has been shown over and over again to prevent heart attacks in patients who particularly have had a coronary stent or have undergone coronary artery bypass surgery. There's fewer women included in research studies, which means there's limited data available. Next slide. So when we talk about risk factors for heart disease, I'm going to go through the traditional risk factors for heart disease, but I also want you to know there's some newer emerging risk factors for heart disease that we will go through in a moment. The traditional risk factors for heart disease include high blood pressure, high cholesterol, diabetes, smoking, unhealthy diet, physical inactivity, and obesity. I often tell my patients that there are 2 risk factors that are unmodifiable, can't change, and that is genetics and age. However, there are so many more other risk factors that can be modified, can be changed, and therefore that's why prevention of heart disease is so important. Next slide. So when we look at non-traditional or emerging risk factors, I want to highlight that there are several chronic diseases that disproportionately affect women's health and impair quality of life as we age. Menopause, of course, occurs, and menopause can introduce changes in your lipid profile. LDL cholesterol, which is your bad cholesterol, HDL cholesterol, which is your good cholesterol, can change through menopause. Similarly, blood pressure can change. Autoimmune diseases are more frequent in women, particularly rheumatoid arthritis and lupus. And these autoimmune diseases, we know, increase levels of inflammation in the body, and we know that inflammation can contribute to coronary artery disease. Breast cancer therapy, including chemotherapy and radiation therapy, can contribute to coronary artery disease. And there's a lot of new cancer chemotherapies that are using the immune system to help target or fight the cancer cells. Unfortunately, this new type of chemotherapy can also affect the heart muscle and can also be toxic to the heart. And so we are becoming more and more aware of this. Depression, stress, history of trauma or abuse really highlights the role of mental well-being, and poor mental health can contribute to the development of heart attacks. Next slide. So gender-specific risk factors can be identified throughout the lifespan. And when we look at young women, we have to think about pregnancy-related risk factors. When we look at preterm delivery and miscarriages, that can be an early sign of poor microvascular health. Microvascular dysfunction means that there's a problem with the small blood vessels in the heart, and we'll talk about that in a moment. High blood pressure during pregnancy could be a sign that that patient will develop hypertension later in life. Similarly, gestational diabetes can be a sign that that patient is at risk of developing diabetes later in life. So identifying these risk factors early can help initiate preventative measures and prevent heart disease later in life. Next slide. The effect of smoking in women is particularly dangerous. Women smokers have a 6-fold higher risk of heart attacks versus 3-fold in men. The risk was higher for women smokers than men smokers, regardless of age. Next slide. Next slide. The symptoms of coronary artery disease that are typical in men is this elephant sensation or pressure sitting on the chest. It's associated often with left arm pain radiating to the jaw, nausea, and sweating. More common in women include shortness of breath, fatigue and weakness, back pain, and abdominal pain. Next slide. So the most common symptom of a heart attack for both men and women is chest pain, but up to 40% of women may not have chest pain, and so we should consider fainting, indigestion, extreme fatigue, nausea, and vomiting are also signs we should look out for. Next slide. Another form of heart disease in women that's very common is congestive heart failure. So I'm going to turn away from coronary artery disease for a moment and speak about congestive heart failure. Common symptoms of congestive heart failure include shortness of breath with exertion, inability to lie flat, and swelling in both legs. Women tend to develop congestive heart failure at an older age than men. Women also tend to develop diastolic heart failure. Diastolic heart failure, put simply, means that the heart muscle is stiff. When the heart contracts, there are 2 phases to think about. So the heart contracts very forcefully and ejects blood into the aorta and all the arteries, and then the arteries supply the vital organs. And we call this form, this part of the cardiac cycle is called systole, when the heart contracts forcefully. But we also have to remember that after systole, after contraction, the heart will relax to fill with blood. And this relaxation phase is just as important as that contraction phase. This relaxation phase, women can sometimes have problems with this relaxation phase in that their heart is stiff and it doesn't relax all the way. It decreases the efficiency of the heart. Blood can build up, fluid can build up in the lungs and in the ankles. And this is what we call diastole or diastolic heart failure. The causes of heart failure in women are often linked to high blood pressure, coronary artery disease, valve disease, and diabetes. There's a rare form of heart failure in women called a peripartum cardiomyopathy, which is related to pregnancy and can occur 6 months even after pregnancy. Next slide. There are other heart diseases more common in women that I'd like to highlight: microvascular angina, coronary artery dissection, and broken heart syndrome. Next slide. Microvascular angina is dysfunction in the microcirculation. It's invisible to traditional coronary angiogram, so it can be difficult to diagnose. But on this screen, you will see a picture of a coronary angiogram. The blood vessels are dark and they look squiggly. And that is the dye that is coursing through the blood vessels. And the main arteries of the heart, we have three major arteries of the heart, but those arteries branch, and then they branch again, and then they branch again, and they become arterioles. And those arterioles, medium-sized arteries, branch some more until they become capillaries. And we call this the microscopic circulation. So you really can't see it. But we do know that women can develop microvascular angina, which is a disease of the small blood vessels that you can't see. Typically presents with chest pain, hard to diagnose because it's not picked up on testing, but responds well to medications. Prognosis is uncertain. Next slide. Another disease I just want to highlight is coronary artery dissection. So on the right side of the screen, you will see an artery that is blocked up with our typical plaque in the arteries. And the plaque can obstruct the flow of blood. It obstructs the lumen, and then the blood does not get distal to that obstruction. But sometimes in women, we can develop a tear in the lining of the heart. And so what you can see on the left-hand side of the screen is that there is a tear in the lining of the heart, and a flap is lifted up because of this tear. And that flap can also obstruct the lumen of the artery and prevent blood from getting to the heart muscle. If people present very similarly, but if diagnosed early on angiogram, it can be treated with medications, it can be treated with stenting. It has an excellent prognosis. Next slide. The final disease that I'll discuss that's more common in women is called broken heart syndrome. It was first described in Japan, so we call the syndrome Takotsubo syndrome. It's usually triggered by emotional or physical stress, and it can present with chest pain and shortness of breath. What happens is there is inflammation or swelling of the distal chamber of the heart muscle, and the heart becomes weak. If identified early, we can start medications, and many times this is reversible. But it highlights the importance of stress and mental well-being when we talk about heart disease. Next slide. So how can I reduce my risk of heart disease? We've talked about many different forms of heart disease. There are many ways that we can reduce our risk of heart disease. There are many ways we can prevent heart disease. There's only two things we can't change. We can't change age, we can't change genetics, but we can change a lot of other things, either through lifestyle or through medical therapy or through structured rehabilitation programs like the one we have at Suburban. So you want to know your blood pressure. You want to ask your doctor about testing for diabetes. This is usually tested with typical physical exams and labs. Quit smoking because that's particularly dangerous for women over men. Avoid excessive alcohol. Learn more about your cholesterol and triglycerides. Understand your body mass index and avoid obesity. Making healthy food choices, and then manage stress level. I'm not saying this is all easy, but this is a way to reduce and prevent heart disease. So thank you for your attention. I'm going to turn it over now to either Cindy or Dr. Hashmi, who straight from the OR, straight from saving lives, has joined us.
Thank you so much, Dr. Colliver. Your expertise in this area is so incredibly valuable. And I know that our participants, I know we have a lot of participants on watching the webinar. I know that they are, that this understanding this knowledge is so very important to them. And I'm sure we're going to have some questions that come in. I should have mentioned earlier that we do have a Q&A chat box at the bottom of your screen, and we would love to hear from you personally. And we will be moderating question and answers at the end with all of our panelists. And maybe we'll even get lucky and everyone will actually be able to join us. But I am so thrilled to introduce Dr. Fayez Hashmi, who, as Dr. Colliver just said, has joined us directly from an open heart surgery case. And we thank you so much for taking the time and for coming to join us this afternoon and giving this time to the members of our community who have logged on to this webinar. So we'll turn it over to you. And if Dr. Hassan is not able to join us, perhaps between the two of you, you'll be able to talk a little bit about interventional cardiology and the TAVR procedure and some of the things that he was going to talk about. We'll give him a little bit more time though while you present, Dr. Hashmi. Thank you so much. We'll turn it over to you now.
Thank you. Thank you, Dr. Colliver. Thank you, Cindy, and thank you, Janine. Nice job preparing and getting everything together. And I'm delighted to be here. I joined here about a year ago, and I've really enjoyed the year I've been here. I feel very much loved and appreciated. So I will talk to you about our addition of services that we have done in the last 1 year with Dr. Matthew and I. We've been working towards adding some more services to our service line. The cardiac surgery is done traditionally with a sternal incision in the middle of the chest, up and down, going through the sternum. And then either you are doing a coronary artery bypass or you're doing valve surgery. Those are gives you a great access, straightforward, been done for the last 50 plus years and proven to be successful in tremendous number of millions of patients have benefited from it. But the thought started coming in the early 90s that the sternum itself, when it is split, it does add to the morbidity of the operation, especially in the elderly, where it causes a lot of negative nitrogen balance, meaning there is a catabolic state and takes a lot of energy out of the patient's overall recovery time. That their hearts are fixed, but their recovery is very slow because of the negative nitrogen balance. They are not in the positive territory. So it takes time. So things have been developed over a period of time to do the operation without opening the sternum. And that's where the term minimally invasive cardiac surgery comes from. That if you can do without opening the sternum through either the right side or the left side of the chest, going between the rib spaces to repair the valves, then the recovery is much faster, the pain is less, and there is some cosmesis to it too. That people don't have very large, big scars, and for some people it is important, not for everybody. But I think so all those things converge to make it an attractive alternative to sternal splitting operation. And as the time has gone, the catheter-based procedures have increased in their complexity and in sophistication and in their adaptation. The surgical crowd has to have some alternative to people who really are not candidates for catheter-based surgeries or replacements, that they can still be the minimally invasive surgical alternative is palatable to them. And so this is how we have embarked upon introducing this to Suburban Hospital. I came from Toledo, Ohio, where we had an established minimally invasive surgical program we were doing. In 10 years, we did about 500 minimally invasive procedures, which included coronary bypass surgery, mitral valve surgery, aortic valve surgery, and aortic aneurysm surgery. And so having that experience along with Dr. Matthew's experience, I think between the two of us, we have several hundred cases that we can say that we very comfortably can offer to the community. As a matter of fact, this week we had, out of the 7 cases we have scheduled, 3 of them are minimally invasive. We did one today. It was a second time operation for somebody who had previous mitral valve and coronaries. And Dr. Matthew and I did that. Dr. Matthew was the primary surgeon. He did a wonderful job through the small 7-centimeter incision just next to the middle of the chest on the right side, and we replaced the valve. And so tomorrow we have a person that we will be doing the same thing, aortic and mitral valve. And then Friday we have a patient who needs a coronary bypass. So I think, having said this, we have in the last maybe 6 to 8 months, we have done about maybe 40 cases of aortic and mitral surgeries here. And I think our numbers are beginning to increase as our community, our medical community, our colleagues in cardiology and internal medicine realize that there is an alternative that we can offer to these patients. And some of these patients are young, and it is important for them to go back to their work, employment, whether it is a desk job or whether it is a manual job. I think they can return to work much quicker as opposed to when you have a sternotomy. The sternal incision has its own complications, such as the most devastating is the mediastinitis. And so offering a non-sternotomy approach mitigates that, because once the mediastinitis occurs, the mortality is pretty high. And the disability from it is even worse. So that's another one aspect of it. The second aspect is that because this incision and the length of the surgical field is much smaller, the incidence of blood transfusion is lower in the minimally invasive cardiac surgery. The third is that infection rate is much smaller because incisions are smaller and generally not through the big fat in front of the sternum. The incisional pain is much less, and so the return to activity is much faster. People can drive earlier and quicker. And so with that, would you like me to answer these questions now, or some of these we can wait till later? Cindy?
Thank you so much. It looks like Dr. Hassan has not joined us at this point, so perhaps we should go forward with some Q&A
Okay.
for you and Dr.
Should I finish mine, or should we answer these questions now?
Oh, go ahead and finish why don't you go ahead and finish your presentation,
Okay.
and then we'll take question and answer when you're finished.
All right. I will just try to show some pictures, really more than anything else. But first of all, I will start. There is another alternative we have offered here in Suburban, is to do off-pump coronary bypass surgery. The off-pump means that we do not have to put patients on the cardiopulmonary bypass, which is a device to divert the blood from the body while you stop the heart to work on it. It is essential to do it in all the valve procedures, but in coronary artery, we have an alternative that we do not have to stop the heart. We don't. So it converts the heart operation into a vascular procedure, where you're just joining the arteries to arteries or joining the veins to the arteries. And off-pump surgery has its own advantages. The first and foremost is that not having introduced the cardiopulmonary bypass or the artificial circulation during the procedure, it prevents certain reactions that the body elicits with the cardiopulmonary bypass. One of it is the overall generalized inflammation, and that inflammatory response then triggers some hormones and triggers some cytokines and stuff, and that can also then trigger other complications. So this prevents that complication. The second is that the off-pump surgery does require less transfusion as opposed to on cardiac bypass, because there is no hemodilution, because we do not dilute the blood in order to run it through the machines.
Dr. Hashmi, I'm sorry to interrupt. Would you like us to be sharing your slides right now? Is there?
Sure, let me just set it up for the.
Okay, perfect. Let us know, and then we can go ahead and share them, and you can let Enette know how to advance them. Okay, thanks.
Right. So the third thing we have introduced is the multiple arterial grafts in our area, which I think has the advantage that, especially in people up to 75 years age, if you can do more than one arterial graft, meaning that instead of taking veins from the legs for all the bypasses, or at least some of them, if we can do majority of the bypasses with arteries from the either chest or from the arm. So the arteries from the chest are called internal mammary arteries. And the biggest advantage in coronary bypass surgery has been use of the internal mammary artery. And it has been since the early 80s, and it has shown that it prolongs life, even if you use one. And then it has shown that if you do two of those, that tremendously increases the risk of the survival by reducing the events that can happen, meaning that blockages of the vein grafts, which occur as time goes on. 50% of the vein grafts do block up in 10 years. But the internal mammary arteries can stay open for 95% of the time, for 15 to 20 years. And there is a survival benefit beyond 15 years that if you have used bilateral internal mammary arteries. So we have done that, and we routinely do at least 2 to 3 arterial grafts and use as few veins as possible. And there are some people who do all arterial grafts, meaning that we take 2 arteries from the chest and 1 from the forearm, and that's the radial artery. And that is the Cadillac of the coronary bypass operation. And that's available, and especially if it can be done without heart-lung machine, I think that is a big plus. Now I will just show you some examples of patients that we have done. Janine, if you don't mind showing the slides. So this is what I was really talking about. 80 to 90% of the cardiac surgery is done through the traditional approach, which is the cardiopulmonary bypass, arrested heart, median sternotomy, and such. Next slide, please. So the choices in myocardial infarction, myocardial revascularization is that if we can eliminate, as I said, eliminate heart-lung machine, if we can decrease the risks by decreasing the non-physiological state, eliminate and reduce the invasiveness, that is not sternotomy, small thoracotomy, or port access, robotic assisted, 1 or 2 IMAs, harvest, totally endoscopic. And that is actually, this is the holy grail. And if we can do that, that's probably the best possible scenario. Next slide, please. This is just we can just skip that. It has been shown that the minimally invasive multivessel coronary bypass surgery, along with hybrid coronary revascularization, can be routinely done. We have, in my previous life before I came here, this was part of our program that we would do 1 or 2 bypasses off pump through the mini thoracotomy, and then the small other branches which were not that critical, meaning there were secondary branches could be treated with stents. Next slide, please. The off pump surgery has been it had its heyday in the early, and then people have slowly gone down because it does take time to develop. It takes time to do it. I think the biggest factor is the patience, and I think the less patience you have, the less time you want to spend on an operation. But once, if you continue doing it, then it takes about the same amount of time, or maybe less, doing it routinely. But other countries in India and Brazil, only almost 90% of the isolated cardiac bypass is done off pump, and in Japan it is about 70% off pump. Next slide, please. So this is the progression of how innovation can facilitate from op-cap to minimally invasive multi-vessel surgery, which is left thoracotomy, off pump, complete revascularization, then robotic. And I think I did about 50 of those, but it is a bigger undertaking. You really have to have a team which is well versed with it. Then setting up is important. Then the robots iterations keep changing. So we started doing them without robot. We can take the IMS down without the robot and still do the same operation. And then the port access is with the robot without even making a bigger incision. So that actually is very, very few people are doing those. Next slide, please. This is an example of a robotic takedown of the IMA. Then through a small incision, you can do that. And this is an example of an off-pump bypass surgery with stabilizers without stopping the heart. You can stabilize the segment where you're working, and you can do the anastomosis. Next slide, please. So these are the multiple choices we have. We can do single vessel, multiple vessels, TCAP. Next slide, please. This is again just you can take down robotically or direct vision. You can do thoracotomy, and this is how we position. And this is actually a patient that we got. This is the technique we will be using on this week when we do a patient with mid-cap. Next slide, please. And this is the stabilizer. It is a octopus inspired suction cups, which keep the little suction on the heart tissue. So this area is completely immobile, and you can then work on the artery by stopping the flow in the artery and then anastomose. Next slide, please. And this is another iteration of, so chest is not open, sternum is not open, which is right here. This is an incision between the 4th and 5th rib. And without spreading too much, we can put these stabilizers in and work on the 1, 2, and 3 arteries here. Next slide, please. And this is an example of left chest open. This is a stabilizer, and this is the artery which is open. And there are these instruments are placed through ports in order to minimize this part of the incision. And you can do up to 3 bypasses this way. Next slide, please. And this is an example of an 82 years old patient we did. Ejection fraction, meaning his heart function was very poor. And so we did a mid-gap by taking the artery from the back of the chest and anastomosing here and here. Next slide, please. And this is that graft. This is the stabilizer. This is the heart. And this is an anastomosis to this artery, which is diagonal, and then the LAD over here. Next slide, please. And this is how it looked from the incision from outside. Next slide, please. This is another example of two vessel bypass through this incision. Next slide. And again, another patient. Next slide, please. And this is that 82. This is with his permission, so this is the HIPAA compliant. And this is another incision. 82 years old gentleman. Next slide, please. Now we'll talk about the valve procedures. There are this is just to say that the mitral regurgitation, which is the leaky mitral valve, which is between the upper left chamber, left atrium, and the lower chamber, which is the left ventricle. And there are three types of these. These two types can be easily repaired, minimally invasive. This can be done as well. And as a matter of fact, we did one this last Friday. So I'll go over it. Next slide, please. This is a incision for a aortic valve, which we do routinely as well. And this is done on the right side. The aorta is sitting right here behind the sternum. And you can do 95% of the aortic valves this way, and as well as aortic aneurysms. And we have done at least 2 aneurysms and aortic valves here in the last 2 months. And in my previous life, I've done a couple hundred. Next slide, please. This is the incision, and this is this is like a surgical TAVR. This is a deployable, rapidly deployable valve, which we can do through this incision, and it cuts down the operating time by almost an hour. Next slide, please. And this is the healed incision. This is a gentleman actually who had an ascending aortic aneurysm, meaning an aneurysm of the artery which comes out of the heart, as well as the valve, and the aortic valve, which was congenitally, or he was born with a 2-leaflet valve. So this is done through this incision. Next slide. And these are the instruments that we use. These are shafted instruments so that we don't really have to put our hands inside. Next slide, please. This is a mitral valve repair for which I showed that. Janine, could we go to that first mitral valve slide? Keep going, yeah. This one. So this is a type where the heart dilates tremendously. So it pulls the mitral valve apparatus so down that valve cannot, these leaflets cannot meet each other. So if we can go back to this. So this is actually a patient of Dr. Begum's. He was a patient who came in cardiogenic shock. Actually, Jeannie, in your office, he was very short of breath, so 911 was called and sent to Suburban, and he was intubated. The intra-aortic balloon was put in. He was in fluid failure with pulmonary edema. Lungs were filled with fluid. The coronary angiography revealed normal coronaries. He had the heart was like 7 centimeters wide. So after we diuresed him, meaning get rid of all the fluid in the lungs, we did this procedure where we did it through right mini thoracotomy without the sternotomy. And we put a sling around the papillary muscles to bring them together so the heart dilatation is mitigated. So the heart is not as wide as it was before, and it prevents it from dilating even further. And then we put a ring on the mitral because mitral valve itself was totally normal. And so he had no leak, and he's recovering, and his heart function seems better than it was before. Next slide, please. And this is a gentleman we did here 3 weeks ago who had a ascending aortic aneurysm and a leaky aortic valve. And we did all those through this incision. And this gentleman is a 70+ years old farmer in Washington County. Very severe mitral regurgitation, couldn't do anything. So we did a minimally invasive mitral valve repair. And he's back to farming and doing well. Next slide, please. This is an example of another aortic valve and aneurysm. A 62 years old gentleman who we did a composite graft here. Next slide, please. This is a mitral valve repair, minimally invasive done. This is a completed procedure. No leak. The heart is filled with saline. Next slide, please. So this is what it looks like immediately after we finish. This is an aortic valve. This is a mitral valve. You can see this is 4 centimeter. So the total length of this incision is about 6 to 7 centimeter. And this is about also 6 or 7 centimeter incision. Next slide, please. And this is an example of off-pump surgery that we do. This is a multi-vessel bypass with, I think this woman had 5 bypasses with all arterial. And you can see these right internal mammary arteries going this way and the left is going behind to the marginals. And this is, the heart is stabilized with this device as I showed earlier. Next slide, please. I think this is probably it, right? So these are the services we offer now at Suburban. And I think hopefully this will distinguish us in this community at least, that we can offer our community alternatives, which are other than the conventional open heart surgery by opening the sternum, or by, if in bypass surgeries that we don't have to put people on bypass heart-lung machine, and in valve surgery, we don't have to open the sternum. Thank you. I'll be happy to answer any questions.
Thank you so much, Dr. Hashmi, for that presentation. I hope that from these 2 presentations, Dr. Colliver with cardiac disease and prevention, and Dr. Hashmi with all of this information about cardiac surgery and some of the new techniques that we're utilizing in cardiac surgery. I hope that everyone who's on the call today really has a great opportunity to understand the true breadth of service that's available here in cardiac care at Suburban Hospital, and also, in our partnership and relationship with Johns Hopkins Medicine. So we do have a large number of questions that have come in, and I know that Dr. Hassan has not been able to join us, so we'll move into question and answers right now, and I'm happy to try to weed through these and try to deliver them to just answer the person who's most appropriate to answer would be great. So I think that you covered this one. We had a question about regurgitation in the heart chamber, and I feel as though you discussed that, Dr. Hashmi. Is there anything else that you'd like to say about regurgitation in the heart chamber?
I think there are 2 valves which are important to understand, and the third one is the aortic valve and mitral, and the third one is tricuspid valve. The most common is actually a mitral valve regurgitation or leaky mitral valve, followed by, I think, the tricuspid valve, and the third one would be, right, Jeannie? Third one would be aortic regurgitation. The tricuspid valve is mostly secondary to the other 2 valve disease. So it happens with dilatation or enlargement of both chambers of the heart because of the pressures and the volumes and extra blood going through.
And I guess the best recommendation here for someone who's asking a question about regurgitation is for them to be having an active relationship with their cardiologist.
Yes. And most of the time, regurgitation is tolerated for a much longer period of time than a blocked valve or a stenotic valve.
Okay, thank you so much. A question here: is minimally invasive valve replacement a possibility for patients who have previously undergone an open heart surgery? So some of these minimally invasive techniques, are they possible after an open heart surgery?
Absolutely. That's in some cases, actually, that's preferable. We actually did that case today, where the patient had a previous mitral valve repair and a coronary bypass. And we went through the side, just like I showed those incisions. We didn't have to open the sternum because that you can damage the heart by opening the sternum and damage the grafts. So it can be easily done. Both aortic and the mitral, both can be done that way in patients who have had previous bypass surgery, or bypass or any other heart surgery.
Okay, here's let's go with this one, and I think Dr. Colliver, this is for you. A patient has put a scenario in the question and answer. I'm a 61-year-old female, borderline high blood pressure, currently on a daily medication treatment, gets an annual EKG. Would you recommend a baseline workup with a cardiologist? This person describes herself as active, exercises every day, eats healthy, never smoked, not overweight, but is a breast cancer survivor with radiation treatment 11 years ago. Does this sound like a good candidate for a cardiac workup with a cardiologist?
So I think it would be reasonable to have a conversation with your primary care doctor, and your primary care doctor is going to be very helpful in estimating your risk of having a heart attack in the next 10 years. We do this estimation based on the traditional risk factors and maybe some of the new emerging risk factors. Particularly if you're postmenopausal, I think it would be reasonable to have a baseline cardiac evaluation.
Thank you. Another question. I've been on statins for almost 7 years post open heart surgery. My liver is not happy, and my cardiologist has suggested I take a statin break. Are there other alternatives to statins that are easier on the liver?
There are many other alternatives to statins, but statin therapy has the most data. The reason we prescribe medicine is we want to prevent heart attacks. We want to prevent a second surgery. And when we talk about prevention, statins number 1, 2, 3, 4, and 5 in terms of our ability to prevent recurrent events. However, there is a section of patients that will not tolerate statins, probably a genetic kind of basis to this problem. And so there are other options like Zydia, Welchol. These are other non-statin drugs that lower cholesterol. And then the newest option, which has been approved, is drugs called Repatha or Praluent that are LDL lowering medications that use a different mechanism than statins. And they are well tolerated in statin intolerant patients. The only problem is they're injectable medicines that you give once every 2 weeks. They're also very expensive and requires a rigorous authorization process, which we will do on my office, as well as Hopkins pharmacists that work in Baltimore help us to get patients approved for these drugs. And we've had some success.
Thank you so much. Now, I know we were hoping to talk a little bit more about TAVR today if Dr. Hassan was able to join us, but I'm hoping one of you might be able to answer this question. Can TAVR be used on any heart valve, an aortic valve or a mitral valve?
So right now the TAVR is for aortic valve.
Okay.
And only aortic stenosis, not for aortic regurgitation, and not in patients who have aortic valve plus aneurysm.
Okay.
And it is it's not for people who are young, meaning we don't really know that what will happen to TAVRs in 20 years or 15 years. We know for other, if you're 50 years old or 60 years old and have life expectancy of 20 to 30 years, I think a surgical valve replacement is the answer. And especially if it can be done without stenotomy, I think that probably is the best of both worlds. The TAVR, there are now developing mitral valve prostheses which can be done through the catheter. And those are, some of them are approved now as valve-in-valve, meaning you have a previously placed bioprosthetic, a PIG valve, and it is deteriorated, and you can put it in there because that has stabilized that area where the valve can go in because of the previous encasement, the valve's housing. But in a valve which has not been treated with surgery before, that still is in development. As a matter of fact, one of my partners in my previous practice has developed one, and he sold it to Medtronic, to Edwards for $300 million. Oh, and now he doesn't have to practice.
Well, I think that person really needs to make a really nice philanthropic contribution somewhere. maybe Suburban, maybe to your work right here at Suburban Hospital.
We'll approach you.
That would be amazing. A couple more TAVR questions, and you may have actually just answered that, but another question was, how long does the TAVR last, which you just talked about a little bit, why they're not used necessarily for young people.
There was a study in Europe last year, a year before, that 50% of the TAVRs deteriorate in 5 to 8 years.
Interesting. Okay. And the follow-up question to that is, can you have a second TAVR, a TAVR within a TAVR?
Yes, that is possible. That is actually probably if you have a TAVR and you're fortunate enough to live long enough, I think it is good. It can be done, yes.
Okay. Let's see. Dr. Hashmi, are there any new therapies, procedures on the horizon for the management and prevention of aortic aneurysms or dissection in those with connective tissue disease? I believe you covered some of that in your presentation, and this person asked that maybe a little bit earlier. But
I think once the gene therapy becomes more sophisticated and then maybe there will be some treatment that you can block the genes or the mutation. But I don't think there is other than to slow down the process of deterioration in the aorta with medications such as losartan or that which reduce your blood pressure. And maybe Dr. Colliver could say something more about that. But that's about my knowledge that you can slow down the process, but you can't stop it.
So I have a good question, probably for both of you. In view of the first presentation, which was Dr. Colliver's presentation, it was interesting to see only one female featured in the second presentation on your minimally invasive procedures that you were showing case studies of. How often are some of these new procedures performed or recommended for female patients?
I don't think there's any difference between men and women as far as the treatment. I mean, the approach is concerned. It can be applied to both, and as a matter of fact, it is very desirable. Especially now, that brings me to another point. It has been shown that off-pump surgery relatively is more beneficial to women than in men. And there was a study of like 16,000 patients studied in the mid 2000s that showed that the women benefited more than men benefited from off-pump coronary bypass surgery. And again, the minimally invasive techniques are applicable to both. As a matter of fact, the first mitral I did here was a lady. Minimally invasive, we did a mitral valve on her. She was a retired nurse. We did a invasive mitral.
I think some of the issue is also that women tend to present later in life, so that there are more medical comorbidities that might affect their surgical risk. And also women tend to wait to seek medical attention. And that's poorly understood. We don't know why, but we do see in observational studies that women tend to wait to be seen, and therefore the diseases progress to the point where maybe they're just not a good candidate for surgery.
Thank you so much. I know that we have reached our time. We do still have a few more questions here, and we would be happy to try to answer those questions. If those individuals, if you don't feel that we did answer your question, please do feel free to reach out to the foundation office, and we will reach out to our wonderful our presenters here and see if we can get those answers for you. And all of these physicians are so amazing to give us this time, and I know that they're very anxious to speak to the members of our community as well. If you have medical questions, we have a tremendous number of exceptional resources here. So I just want to take this opportunity to thank everyone who joined us for this presentation. It will be available. We did record this presentation, so it will be available as a recording that we can send out afterwards if people are interested. If you didn't have a chance to see it, we will certainly try to get Dr. Hassan on another presentation in the near future with some of our additional cardiac experts. And we will be covering additional topics beyond cardiology and cardiac surgery and interventional cardiology in the future through our innovations in clinical care presentation. So thank you so much to Dr. Hashmi, to Dr. Colliver, and to all of you for being with us, and to all of the donors who have joined us on the call today. Most of what we do here couldn't be done without you. You allow us to really be exceptional, and we are so incredibly grateful for that. So please do reach out to us, and everyone continue to stay safe and healthy. Thank you so much, and have a great evening.
You too, Cindy. Thank you. Thank you, Jeannie.
Thank you.
It was great to see you. Yeah.